Hello, GAPIO members, friends, and colleagues. Good morning, good afternoon, or good evening, depending on which part of the world you are in. Also, belated wishes for a Happy New Year 2021. My name is SChatterjee. I am a senior consultant physician in the Department of Diabetes and Endocrinology at Apollo Gleneagles Hospital, Kolkata or Calcutta, India. I've been given the job of moderating this session on diabetes and metabolic medicine, a task which I have accepted with humility and alacrity. We have three very interesting sessions ahead of us. The first one, Breakthrough in Diabetes. A speaker will be Dr. Subhas Wangnu of India. The session will be chaired by Dr. Gautam Bodiwala from the United Kingdom. The second session, Latest Advancement in Lipid Management. Speaker will be Dr. Om Ganda from the Joslin Diabetes Center of United States. Chairperson will be Dr. Robi Kohli, also from the United States of America. The third session is on a very contemporary topic in view of the current pandemic, that is vitamin D and COVID-19, truth versus hype. And speaker will be Dr. Amrish Mittal from India, and the session will be chaired by Dr. Harsh Mahajan from India. Please note that you may send your questions in the chat box, and please mention your email ID, and we'll send you the answers within 1 week of this meeting. Now I invite the speakers and the chairpersons. To begin with the first session, I have the pleasure and honor to introduce the session chairperson, Dr. Gautam Bodiwala. Dr. Bodiwala is acknowledged as one of the pioneers and experts in the field of emergency medicine, both nationally and internationally. He is the past president of International Federation of Emergency Medicine and EC member of GAPIO. He was awarded Commander of the British Empire, one of the highest four honors by Her Majesty the Queen, first to an emergency medicine consultant. The emergency department in Leicester is named after him as Gautam Bodiwala Emergency Department, the only one in the entire United Kingdom. I'll request Dr. Bodiwala to kindly introduce the first speaker, Dr. Subhas Wangnu.
Thank you to the moderator for my kind introduction. Thank you also to GAPIO organizers for asking me to chair this particular session and introduce the next speaker. It's a great pleasure and privilege to introduce Dr. Subhas Wangnu, an eminent endocrinologist of India. Dr. Wangnu is currently heading the Apollo Center of Obesity, Diabetes, and Endocrinology at Indraprastha Apollo Hospital, New Delhi. His interest goes beyond obesity and diabetes into the thyroid, reproductive endocrinology, and pituitary disorders. And he has written numerous publications. He has been involved in 3 clinical trials of international fame. Dr. Wangnu is actively involved in teaching and training of DNB trainees in endocrinology for a decade. He has the honor of being the honorary physician endocrinologist to the former President of India. Ladies and gentlemen, I ask you to welcome Dr. Subhas Wangnu to deliver his lecture. Thank you very much.
Hello, I am Dr. S.K. Wangno. I am currently working as a senior consultant endocrinologist and diabetologist at Apollo Center for Obesity, Diabetes and Endocrinology, Indraprasth Apollo Hospital, New Delhi. Today we are going to talk about the breakthroughs in diabetes. In another 6 to 8 minutes, I am going to take you through the breakthrough in diabetes, which basically surrounds around advances in the guidelines, breakthrough in the treatment option, and some of the advances in technology in management of diabetes. Now, coming to the advances in the guidelines, we have evolved over the years, and there's been a pragmatic approach is sort of a 360-degree approach for the glucose control plus what we call the cardio renal metabolic component of the diabetes in order to reduce the mortality. So the newer drugs basically focuses on the glucocardio renal approach. So this is a busy slide, but nonetheless, if you see, we have advanced from the previous guidelines, which are basically focusing on the stepwise glucocentric approach. Now, our main major of focus is the glucocardiorenal approach. What do you mean by this approach? The approach basically focuses on not only the glucose control or the control of the blood sugars, but also simultaneously to protect your heart and the kidney. For example, if you see this slide, these are the guidelines from the Association of the Clinical Endocrinologists, American Association of Clinical Endocrinologists, where on the left-hand panel, if the baseline HbA1c is 7.5, the first drug, apart from the metformin, remains as the GLP-1 receptor agonist and SGLT2 inhibitors. And these drugs are basically recommended independent of the glycemic control if the patient is having established atherosclerotic cardiovascular disease or high risk chronic kidney disease stage 3, or patient is having heart failure with reduced ejection fraction. Then the main stay of the treatment starts with the GLP-1 receptor agonist or the SGLT2 with proven efficacy in the cardiac outcome. So this has been the major breakthrough in the guidelines that initially we used to be glucocentric, start with metformin. If the sugars are not controlled, then we have to choose out of 5 classes of drug. But now the main focus is that this drug we have to choose independent of the glycemic control and also in order to prevent the ongoing cardiac and the renal complication. Similarly, if the HbA1c is on the higher side, maybe between 7.5 to 9, again, if you are having a combo therapy, then in the combination of therapy along with the metformin, you are supposed to add SGLT2 inhibitor in order to prevent heart failure, kidney complication, and the cardiovascular outcome. And if you want to put the patient on 3 drug combination to have immediate control, apart from metformin, you are supposed to add these 2 more drugs. One is the SGLT2, other the GLP-1 receptor agonist. But one thing to focus that HbA1c is more than 9%, it is better to start with the insulin. Why the breakthrough in the treatment option? The new medication and the paradigm shift in the treatment regimens has been basically shown on the basis of evidence and the benefits in the all the outcome trial. If you're using the SGLT2 inhibitor, there are more impact on the renal parameters, which is more than the heart failure and the cardiovascular death, which is more than the 3-point MACE, that is the CV death, non-fatal MI, non-fatal stroke, or admission for the unstable angina. Similarly, GLP-1 receptor agonists are primarily meant for the initial 3 point MACE improvement, CV death, non-fatal MI, non-fatal stroke, more than the heart failure, because SGLT2 are the better drugs for the control of heart failure. The GLP-1 receptor agonist, MACE is on the priority while the heart failure comes on the second priority. So the summary of the key features of the breakthrough in the treatment option, what I told you, the introduction of the newer drugs, and now in the line of the insulin treatment, we have a new insulin, the basal insulin, which can be given once in a week. And this has been basically manufactured by the Novo Nordisk by doing the molecular modification, causing the longer half-life of the insulin. And this is termed ICODEC. It interacts with the insulin receptor to activate the same signaling pathway to give the same full metabolic effects as the insulin. And icodec does not demonstrate increased binding to IGF-1 receptor and has very low nitrogen potential and also low hypoglycemic potential. Even continuing through the breakthrough in the treatment option, now there have been two new drugs which has been basically given FDA approval, and which has been given what we call the CV reduction drug in the US, Ozempic. Ozempic is basically indicated for the cardiovascular risk reduction, and it has been basically approved in the US with adults with type 2 diabetes, reducing the risk of major cardiovascular events. The second drug is Ribulus, which is again given to the patients who have experienced at least one of the coronary events, and they have shown a non-inferiority trial giving a non-inferiority hazard ratio of 0.79. So Ribulus is again, and it has been shown in the SOUL trial that this drug, which is given daily in the form of oral, is a GLP-1 receptor agonist, is showing a good benefit trial in patients to reduce the 3 point MACE. Now, coming to the again the last few slides, one or two slides, breakthrough treatment option in technology. Technology has come a great way for the diabetes treatment. We have now closed loop insulin pumps. The latest one is T-Slum, and it has a control IQ technology, and it is the artificial intelligence based inbuilt algorithm. Then we have real time continuous glucose monitoring system, and now you're using time in range. Every glucometers and the insulin pumps have come with the data. Whenever they measure the sugar through the CGMS, they give the data how many hours the patient was having a good glycemic control, which is called the time in range. And we know the 70% of the reading in 24 hours should be between the time and range. So this time in range has been, along with the HbA1c, as a complementary mode to see the good controls. So we cannot forget HbA1c, but the limitation on HbA1c is that it only provides an approximate measure of glycemia, unable to address hypoglycemia. While the time in range will tell you every day how many hours patient was in good glycemic control, whether that is going to prevent the ongoing vascular complication, and it helps to take the management decisions. So this is breakthrough in the treatment option, what we call the time and range. You can see the three circles. In the first, the patient was 40% in time in range. In the second, 70% time in range. And the third, 100%. To get the 100% is very difficult, but if you are able to maintain 70% time in range, then it is absolutely okay. So SMBG, that is the self monitoring of glucose control, has been replaced by the continuous glucose monitoring of blood glucose, and has been replaced by the full glucose profile monitoring, where it needs no calibration, long sensor use, relatively affordable, and the only problem, it doesn't give alarms or hypos. But while in some of the CGMs they have the alarms for the hypo, which has the advantage over the FCGM, the CGM. So these are the basically breakthrough in the diabetes. I hope I have given a nutshell about the breakthrough in the treatment option, breakthrough in the guidelines, how we treat diabetes, breakthrough in the technology, how the technology is revolving around giving better care to our diabetic patient. Thank you very much.
Thank you, Dr. Bodiwala, for chairing the session, and thank you, Dr. Wangnu, for your excellent talk. We move on to the next session, which will be chaired by Dr. Robi Kohli. Dr. Ravi Kohli is board certified psychiatrist with additional qualifications in addiction, forensic, and geriatric psychiatry. He is the psychiatric medical director at Southwestern Pennsylvania Human Services. Dr. Ravi is former clinical assistant professor at the University of Pittsburgh and West Virginia. Dr. Ravi is member, County Commissioner, Mental Health Advisory Board, Washington County, Pennsylvania, and is currently the Vice President of American Association of Physicians of Indian Origin. Dr. Ravi was the past president of Association of TELG Medical Graduates in the United States. I will request Dr. Ravi Kohli to introduce our next speaker, Dr. Om Ganda.
Thank you, Dr. Sanjay Chatterjee. And also thank you, Gapio, for giving me this opportunity to talk about Dr. Om Ganda. Dr. Om Ganda graduated from medical college at SMS Medical College, Jaipur, and then received his MD from All India Institute of Medical Sciences in New Delhi, and he started his tenure at Joslin Diabetes Center, Harvard Medical School in 1973. He is currently the clinical associate professor there and also serves as medical director of Lipid Clinic of Joslin Diabetes Center and also the chair of Clinical Guidelines Committee. He has published over 160 articles in high-impact journals and contributed 25 book chapters. He is a recipient of Distinguished Physician Award of New England in 2016 and also recently honored by People's Choice of New England Healthcare Pioneer Award. Dr. Ganda also serves as a member of Executive Committee of GAPIO, Global Association of Physicians of Indian Origin. Here is Dr. Ganda.
Hello, this is Dr. Ganda. I want to thank the organizing committee of the GAPIO to invite me to give this brief presentation on the latest advances in lipid management, endocrine basis of novel approaches. As everyone knows, cardiovascular disease has now become the leading cause of morbidity and mortality, even in the Asian countries, surpassing the non-communicable diseases. So one thing we all know when it comes to lipids, that there is now incontrovertible evidence for long-term efficacy and safety for the HMG-CoA reductase, otherwise very well known as statins, in reducing cardiovascular events. So the question comes up, what is the ideal LDL cholesterol level when we treat our patients? Well, this particular table shows you that there is not a consensus on this point, but it's very clear now, more and more getting clearer, that the lower you go safely, and if the patient can tolerate it, the lower is better. So as you can see here towards the lower part of the table, that as opposed to AHA, ACC latest guidelines and the ADA guidelines, ACE in 2017 suggested a goal of less than 55, and European Society of Cardiology in 2019 suggested that it should be even less than 40 if somebody had second event in less than 2 years. And most recently, just a couple of months ago, Endocrine Society kind of agreed with that goal, so somewhere between 40 and 50 range. And these are for people with established cardiovascular disease or multiple risk factors. Now, in this review article that I published a couple of years ago, this is kind of a laundry list, so to speak, of non-statin options. What if the patient cannot tolerate statin? Or if the LDL goal is not met? knowing that the goal is lower and lower. We have two evidence-based options so far, in spite of this long list. One is the ezetimibe, which is a cholesterol absorption inhibitor, very easy to take and very simple pill once a day. The second option that has been approved for the last few years is the PCSK9 inhibitors, of which we have two agents available. And finally, I'll say a word about bempedoic acid, the most recent drug that was approved by the FDA for LDL reduction, but the cardiovascular trial is still in progress. This drug is a ATP citrate lyase inhibitor, a very novel concept, which makes it an oral pill as opposed to the injectable PCSK9 inhibitors. So the PCSK9 inhibitors, in a nutshell, given the limited time I have, they really block the breakdown of the LDL receptor, either as an antibody that can be made to the secreted PCSK9 from liver, or by blocking its synthesis by siRNA latest technology, a technology that won a couple of people Nobel Prize several years ago. So a lot of new drugs are being developed in that exciting manner. This is just an example of the two PCSK9 inhibitor cardiovascular trials carried out in people with very high risk of cardiovascular disease. You can see that these drugs are magical in reducing LDL cholesterol. On top of statins, they reduce LDL cholesterol by 50 to 60%, depending upon which trial you look at. That's really remarkable and helps people who are either statin intolerant or have very high LDL cholesterol. Now, bempedoic acid, an oral drug, an ATP citrate lyase inhibitor, shown here, you can see it lowers LDL cholesterol more modestly, about 16% or so. But in doing so, if you add it to statin in the lower dose, you can still get very good efficacy. Or you can add it to ezetimibe, and you can get up to a 30% reduction in LDL cholesterol. So not yet completed, but the cardiovascular trial is still underway. You can expect the results in a couple of years. Now, this is another review that I just want to simply point out a couple of things. That what about beyond LDL cholesterol? Once your LDL goal is reached, particularly in people with diabetes or those at very high risk due to multiple coexisting risk factors, one can consider either that LDL goal being suboptimal, we are not getting reduction in events, or we can think about triglyceride-rich remnant particles, which are highly atherogenic, inflammatory, prothrombotic. The question of triglyceride reduction has been kind of debatable because there's never been a good trial to show any effect of triglyceride-lowering drug in reducing cardiovascular risk. There are some novel fibrates now being developed and currently in trials. And then there's one class of drug called the omega-3 fatty acid, which is a purified EPA or icosapent ethyl, a trial in which I was also involved. It's a multi-center trial completed a year and a half ago. 8,000 people with prior cardiovascular disease, 71% of them, and almost 60% had diabetes. Everybody was on statin. And you can see the median LDL at baseline was 75, triglyceride 216, HDL 40. They were given 4 grams of this purified omega-3 fatty acid called EPA versus placebo. And look what happened. Remarkable. Even we as investigators found it hard to believe that after about 4.5 years, there was further 25% reduction in the overall cardiovascular endpoints. Look at the p-value here. And if you look at the traditional 3-point MACE, CVD, MI stroke, again, 26% reduction on top of statin, never been shown in any other trial. So this is the most exciting new development beyond statins and beyond LDL cholesterol. Finally, the question comes up, what if we don't want to take a fish oil, such as EPA? Can we achieve this with some vegetarian sources, which provide us alpha-linolenic acid, which is alpha-linolenic acid is an omega-3 fatty acid as well, but it's really much weaker. Can it be an alternative? I doubt it, because you don't get that much. Whether you eat mustard greens, walnuts, soybeans, flaxseed, or chia seed, these are all very, very important sources of omega-3 fatty acid, but you will have to eat a huge amount to get the amount of alpha-linolenic acid, or ALA, in comparison to the EPA from fish oil. So we have a lot more to learn, and we still don't know the exact mechanism through which omega-3 fatty acids not only reduce triglyceride, but also reduce cardiovascular disease by some independent mechanism, such as membrane stability and other effects that are being very feverishly being looked at right now. And we will know more about the mechanism of action of EPA in the coming few years. So with that, I want to thank you very much, and I invite your questions either by chat or live. I'm not sure whether that will be possible, but thank you so much.
Thank you, Dr. Ravi, for chairing the session, and Dr. Om Ganda for your wonderful presentation. Now I have the pleasure to introduce our next chairperson, Dr. Harsh Mahajan. Dr. Harsh Mahajan is an eminent radiologist and pioneer in the field of MRI in India. He is the founder and chief radiologist of Mahajan Imaging in New Delhi and chairman of Center of Advanced Research in Imaging, Neurosciences and Genomics. Dr. Mahajan has been conferred with Padma Bhushan Award in the year 2002. He is a former radiologist to the President of India. He has been the national president of Indian Radiological and Imaging Association and Indian Society of Neuroradiology. Dr. Mahajan has delivered over 1,500 guest lectures and has more than 50 publications in index journals. I'll request Dr. Mahajan to introduce the next speaker, Dr. Amrish Mittal.
Thank you very much, Dr. Sanjay, for that kind introduction. I would like to take this opportunity to thank the Global Association of Physicians of Indian Origin for giving me an opportunity to chair this very prestigious session during the Global Indian Physicians Conference. It is now my very pleasant duty to introduce my close friend, Dr. Amrish Mittal, Padma Bhushan and Dr. B.C. Roy awardee. Dr. Amrish Mittal is chairman and head of endocrinology and diabetes department at Max Healthcare, a group of 16 hospitals. He heads the entire endocrinology and diabetes departments of these hospitals. Dr. Mittal, as we well know, is a domain expert on the governing body of National Health Authority and is president of the All India Institute, AIMS, Gorakhpur. He has recently been honored with the Laureate Award from Endocrine Society of the USA for international excellence. It's my pleasant pleasure to invite Dr. Mittal to start his lecture. Dr. Mittal, please.
Thank you, Gapio, for this opportunity to present here. And I also thank the chair and the moderator, Dr. Sanjay Chatterjee and Harsh Mahajan, for this session. Today, I'm going to talk about vitamin D and COVID-19, the truth versus hype. We hear so much about vitamin D, but what exactly is the truth about vitamin D and its relationship to COVID-19 is what I'm going to try and explain the next few minutes. Vitamin D has been known to have some role in preventing acute respiratory infections. It also has been thought to have some role in other respiratory infections, but particularly in acute respiratory infections. And it has been shown in this oft-quoted meta-analysis that vitamin D supplementation can actually reduce acute respiratory tract infections. And I think we'll just, to summarize this, this meta-analysis showed that it worked. It worked whether it was given daily or weekly, and the effect was maximum in those who had 25D levels of below 25 nanomoles or 10 nanograms per mil. And I think that's important data, that seriously deficient vitamin D populations was helped by supplementation of vitamin D in reducing respiratory tract infections. And there's other data on also reducing severity of the infection, which we are not discussing today because we're going to move to COVID fast. What is the story of COVID here? We know that broadly vitamin D does seem to help in acute respiratory infections. COVID, let's look at straight away some of the studies, and then I'll come to the summary at the end. So this particular study looked at hospitalized older patients with COVID-19, and those who had COVID-19 positive results were actually had a 25D level of 27 nanomoles. And those who had COVID-19 negative results had a 25D level of 52 nanomoles, indicating that those who presented with serious disease, actually, older patients, but among them, those with COVID-19 positivity had lower 25D levels, clearly lower 25D levels. And this, of course, is the much cited study from PLOS One, where they actually looked at the relationship of 25D to outcomes. And they really found in this study that in 235 patients infected with COVID-19, 9.7% of patients who were older than 40 years who had 25D more than 30 nanograms or 75 nanomoles died. And 20% of those who had 25D level of less than 30 nanograms actually died. So looking at, like, very grossly, looking at mortality, it seemed that people who had levels of 25D below 30 nanograms had a higher mortality in this particular retrospective analysis. And they were also had a lower significant reduction in CRP, increased lymphocyte percentage in those who had lower D levels. So it was suggested that people with higher D levels may have better outcomes if they get COVID infection, both in terms of actual hard outcomes like death, or also in terms of surrogate markers like CRP and lymphocyte percentage. So based on this data, they said they recommend vitamin D supplementation to achieve a blood level of at least 30 nanograms to potentially reduce the risk of acquiring the infection for all COVID-19 patients, especially for those hospitalized. But this study was criticized a lot because this was not really an intervention study. And they kind of extrapolated the data, so people thought that the conclusion was way beyond what the study itself showed. So this study was really criticized. But anyway, this is an important study from Spain, which again is a retrospective but case control study. 216 COVID-19 patients, 197 population-based controls. Of the 216, 19 were on D supplements, so we leave them out. In COVID-19 patients, 25D levels were 13 nanograms. In COVID-19, in controls in the population, the 25D levels were 20 nanograms. So we are now comparing COVID-19 positive patients versus normals, okay? Population-based controls. So we're not comparing within hospital patients. So what they found was that they suggested, based on the data, that a lower 25D made people more prone to get significant COVID-19 because they had to be hospitalized. So hospitalized COVID-19 patients clearly had lower D levels as compared to the general population. However, and this somehow never caught the headlines, only the upper part was discussed all the time. They did not find any relationship between vitamin D level at admission or vitamin D severity and the severity of the disease. So the severity of vitamin D deficiency did not correlate with severity of outcomes. In fact, they found no correlation at all. So this study is a mixed bag. It suggests that those with lower vitamin D may be more prone to COVID-19, but it also suggests that COVID-19 level at admission did not correlate with outcomes in any way. I think this is a very important finding in this study. And one of the better done sort of studies, which is a supplementation study, which used 25-hydroxy D, that is a calcifediol, and not cholecalciferol that we commonly use. And they found that it is a very small study. I mean, 50 patients, 26 patients. They found that in patients where they gave calcifediol in the hospital, again, hospitalized patients, they found that there were no deaths in the calcifediol group, but there were but 2 out of 26 patients in the untreated group died. So calcifediol patients who received calcifediol seem to have lower mortality, but you can also see that the numbers are really small here. So it's pretty hard to really reach solid conclusions. What they are saying is, of course, that the high dose of calcifediol significantly reduced the need for ICU treatment of patients requiring hospitalization due to proven COVID-19. So both ICU treatment and deaths were clearly lower in patients who received calcifediol as compared to those who did not receive it. Now, we did a small study on this, actually not so small. We did a study in this, which is under publication. So I can't give all the results out, but I'll give you some glimpse of what actually we found. Uh, if you look at the distribution of 25D levels, this is 401 consecutive patients were studied, right? People who were admitted to the max wards with COVID-19. And you can see that a very high proportion, 25% of them were still in the severely deficient zone, that is blue zone, severe deficiency. So, as our studies in the past and those of others have shown, vitamin D deficiency is widely prevalent in Delhi, in India overall, but especially in metros and in Delhi. And here too, we find 25% people below 10. Actually, that's an improvement. There was a time when we used to find 40, 50% of people below 10 nanograms or 25 nanomoles, if you will. Another 100 odd, that another roughly 24% were actually in the deficient zone, that they were between 10 and 20. So still weren't achieving even a modicum of vitamin D sufficiency or normalcy, if you like to call it. Third group was 25D between 20 and 30, which is truly the good group, so to speak. That is 67, that is only 16%, and 33% were above 30. And a very small proportion had vitamin D toxicity, probably because they'd taken, or hypervitaminosis D, because they'd taken too much vitamin D. This yellow sliver you see here. So you can see a fairly wide range of D levels in the population that probably depended on whether they were taking vitamin D or not in the outpatient setting. And of course, we didn't have any data to confirm whether they were taking vitamin D supplements or not. But the fact is, we had representation from all stages of vitamin D deficiency. And the important part is that regardless of the vitamin D category, the proportion of severe and mild cases was similar. So whether you had severe D deficiency, below 10 nanograms, 25 nanomoles, or you were sufficient, really above 30 nanograms or 75 nanomoles, your chances of getting a severe form of COVID was the same. So quite clearly, it did not make a difference. And I will also say, since part of the study is online already pre-reviewed, uh, the level of D at admission did not seem to have any correlation with the overall outcome. So quite clearly, this shows that whatever vitamin D might be doing, it's obviously not something that can be fixed acutely, and giving vitamin D at that time or raising the levels suddenly probably won't have much of an impact based on the kind of data that we have seen. And now, of course, we wrote a review on this a couple of months ago with Manju Chandran, vitamin D and COVID-19, dousing the fire, averting the storm, meaning either we are trying to prevent COVID-19 infection by keeping the population vitamin D sufficient, that is averting the storm, or dousing the fire. So you really have to see what we are going to do. Are we going to try and suppress the inflammatory response that happens in these patients, or are we trying to build their immunity in a chronic kind of situation and help them reduce the risk of getting COVID-19? So the conclusions are that, are individuals with vitamin D deficiency more prone to COVID-19 infection? There is some evidence. There is some evidence from literature that people who are vitamin D deficient are more likely to get struck by COVID-19. And obviously, we should, just based on common sense and our bone data that we've been presenting over so many years, that we need to maintain good optimum 25D levels in the general population, and 20 nanograms is a good number to work with. So anywhere between 20 and 30, but many people say it should be above 30. But quite clearly, there is no confusion. It should be above 20 for sure, and above 30 preferably. Do people with vitamin D deficiency and COVID have poorer outcomes? The evidence is inconclusive. We're really not sure. The data we are showing is not convincing. Our own data did not suggest that. Does administering vitamin D in hospitalized patients improve outcomes? There's inconclusive evidence again. One study shows some benefit, another does not show. So we really don't know. And should we be using large doses to avert storms? Should be looking at that level of 50, 55 nanogram, which is a common level that some people try to achieve in this situation. And those who believe that a very high D level can actually reduce inflammation very significantly believe that you should take levels to that. But most vitamin D workers and most scientists don't believe that. So there's really not much evidence there. So in short, everything is inconclusive at present, but I think it's common sense good sense to try and maintain our 25D levels above 20 at least, and maybe above 30 in general. But it's not necessary that supplementing vitamin D acutely in hospitalized patients is really going to make a difference to the outcome. Thank you very much.
Thank you, Dr. Mahajan, for chairing. And Dr. Mittal, thank you very much for a very nice presentation. Before we conclude this session, I thank all the speakers and chairpersons for their presence and for sparing their valuable time. I thank all the participants also for attending and also sparing their valuable time. Finally, I have some take-home messages pertaining to this session. So there are some take-home messages. I'll begin with Dr. Subhas Wangnu's presentation, Breakthrough in Diabetes. There has been a tremendous growth and advancement in diabetes care and research. There has been a paradigm shift in the recent years in the approach to type 2 diabetes mellitus. From a glucocentric approach, we have shifted to a diabeto-cardio-renal approach. Newer medications have come with added cardiorenal advantages. The GLP-1 receptor agonists have shown benefit in atherosclerotic cardiovascular diseases. SGLT2 inhibitors have shown benefits in cardiovascular death, heart failure, and renal problems. Once a week basal insulin icodec will improve initiation, and as you all know, how difficult to initiate a person on insulin, and also improve adherence to therapy. Once a week GLP-1 receptor agonist semaglutide, marketed as Ozempic, is very convenient, being once a week and already shown cardiovascular benefit in outcome trials. Glucose monitoring with continuous glucose monitoring systems have shown benefit in achieving more time with the time in range, and when used in addition to HbA1c, it will be a useful tool for management. Next speaker was Dr. Om Ganda. He has thrown a lot of light on advances in lipid management. He started with a fundamental question: what should be the ideal LDL goal? Various august bodies like the American Diabetes Association, American Heart Association, etc., they have recommended a goal of less than 70 milligram per deciliter to be safe, or even lower. In secondary prevention, they have recommended lower is better if tolerated. Several non-statin options have been available recently. Ezetimibe and PCSK9 inhibitors like evolocumab and alirocumab have received approval from regulatory authorities. PCSK9 inhibitors provide most profound LDL reduction with proven cardiovascular benefit. Bempedoic acid, a new agent, when used with statin, provide modest LDL reduction, and the cardiovascular outcome trial is ongoing. Triglyceride-rich lipoproteins, as you all know, they are very highly atherogenic, and for residual risk reduction, they need to be addressed. Omega-3 fatty acid, or EPA, or icosapentaenoic acid, has shown significant risk reduction in cardiovascular outcome trial. And finally, Dr. Amrish Mittal have spoken about vitamin D and COVID-19. This is a contemporary problem. Several trial reports available, however, the data is inconsistent. One meta-analysis of many studies have shown that in subjects with very low vitamin D levels, supplementation of vitamin D improve outcome of chest infection. In a Spanish study, COVID-19 patients had statistically significant lower levels of vitamin D compared to non-COVID patients. However, vitamin D concentration did not correlate with severity of infection. In their study, that I mean Dr. Amrish Mittal study on COVID patients at Max Hospital, vitamin D level at admission did not correlate with severity of infection. In spite of inconsistency of results, we all think it will be pretty prudent to maintain a vitamin D level at an optimal level of 20 to 30 nanogram per milliliter. Finally, thank you very